Great. All right, so we are going to get started to stay within 2 minutes of being on time. I am so excited to be leading this panel of wonderful colleagues and experts on high-risk patients, really from the medical oncology standpoint. I'm Jennifer Klemp. I'm a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center, and I'm also now working with Caris Life Sciences. I would like each of my distinguished panel members to introduce themselves, starting with Dr. Ma.
My name is Cynthia Ma. I'm a professor of medicine from Washington University in St. Louis. I'm a medical oncologist specializing in breast cancer.
Hi. Can you hear me? Yeah. Okay. Priyanka Grover. I'm a breast imaging radiologist. I'm based in South Florida, and I'm predominantly here to talk about the imaging and diagnostic guidelines. Thank you.
And I'm Christina Mirabal-Beal. I'm a radiation oncologist with Genesis Care, based in Fort Myers, Florida, where I'm the director of our regional breast cancer program at our cancer center.
Great. Thank you all. And as you can see, we have a nice multidisciplinary panel to have a discussion really kind of highlighting some updates in risk assessment. We always like to kind of give what are the current guidelines, what are the current target populations, how do we incorporate this into shared decision making for your patient, thinking about treatment planning as well as next steps for your survivors, and then what are some sort of new opportunities that are just emerging, and how do we incorporate those into practice. So this bubble diagram I've used for years, but we keep adding to it. And as you can see, there's a multitude of risk factors that go into risk for breast cancer, some of which are modifiable and some of which are not. But I think the other important piece of this is some of the things that we have really added over time is the genetics bubble has obviously gotten bigger, not just when we think about germline, but there's other risk factors dealing with race, ethnicity, metabolic factors. There's a variety of things that influence risk. We also know that as we think about some of the modifiable risk factors, I have a slide that I won't show, but it shows, yes, we have a huge risk from germline mutations, but because of the incidence of being overweight or obese, that risk factor is, and the magnitude of that risk factor has definitely sort of overtaken because of the number of patients that fall into that category. So we really have a lot of moving pieces, thinking about it from both what can we do for risk of an initial breast cancer, and then in our survivors, what do we do when we think about risk of second primaries or reoccurrence and secondary screening as well as prevention. The important part to think about is this really hasn't changed that much, but what has changed is our better understanding of what types of germline mutations fall into the hereditary piece of the pie. And so I think that's been great with the expansion of larger panels so we can test for more genes. This definitely continues to be refined and is part of that sort of update. So we can give you that information without having to go back and reread all the literature. I'm going to let Dr. Ma quickly kind of go through the difference of germline and somatic and how they relate to each other.
Sure. So, as a breast oncologist, when you order a genetic panel for a patient's cancer, you may see mutations, but we have to think about is that a germline mutation or is that a somatic mutation, and distinguishing that is important. And so germline mutation refers to mutations that occur before the conception. We all have, in each of our cells, we have like 23 pairs of chromosomes. We know one pair comes from your father and the other pair comes from your mother. So, mutations in the, each cells, these are called germline, and they are inheritable. So the somatic mutation, however, refers to those that occurred after conception that can cause cancers, and also certain germline mutations could predispose to certain type of breast cancer. So, for example, BRCA1 mutation tend to have triple negative breast cancer.
Great.
So here just lists a panel of genes that have been implicated that's as germline mutation could cause higher risk of breast cancer. We call them hereditary breast cancer, and the ones that highlighted in red are the higher penetrance genes like BRCA1, BRCA2, PALB2, P53, and CDH1. We know that these mutations in the germline could cause a much higher risk of developing lifetime risk of breast cancer. But there are also other genes that you may have to consider family histories like RED51C, RED51D mutations, for example.
And Dr. Ma, do you feel that, especially in practice with our patients, hearing that they have a pathogenic variant, or even when healthcare professionals don't see these very often, do you feel it's sort of one size fits all, or do you feel like there's a good understanding in the community of how to handle the level of penetrance and the strategies for managing those patients?
Yeah, that's a very good question, especially with the multi-gene panels being ordered now. You know, a lot of times we would see there's a pathogenic mutation in one of the genes, may not be BRCA1, 2, but could be, you know, CHEK2, or could be other genes. However, we do need to recognize that these genes are different. They have different penetrance. So, in my clinic, I usually, also ask medical genetics counselors to help, to discuss with the patient their risks for a new breast cancer, and also their family members. So really, we need to kind of treat these individually.
Yeah, and I think there's some nice literature out by Dr. Domchek from Penn, where they dove deeper into the perceptions both of providers and patients. And what you saw was, whether it was even a variant of uncertain significance or regardless of the penetrance, there were a lot of patients and undergoing procedures which we may have normally kept for higher penetrant gene carriers. So I think there's a real variety of how patients are managed. So important to kind of know how we have that shared decision-making discussion with our patients based on the penetrance of those mutations. But also, once again, taking in patient preference and their anxiety and so forth.
Yeah, so who to test? As a breast oncologist, I see our breast cancer patients. So, the first thing is who do we test? So NCCN has continued to update their recommendations based on, our treatment strategies. For example, now we have PARP inhibitors for high-risk HER2-negative breast cancer in the adjuvant setting, and also in the metastatic setting in patients who had chemotherapies. So with germline BRCA mutation, and that led to the updates that patients at any age of breast cancer, if they're potential candidate for treatment decisions, like if they needed PARP, they may help to identify whether they're candidate for PARP inhibitor, either in the adjuvant setting or in the metastatic setting. So those are the good consideration. Make sure that you order the germline testing when a patient diagnosed. And also in younger patients who are age 50 or younger, in addition, there are particular pathology or histology of breast cancers that we pay particular attention to their hereditary risk. For example, at any age, if the patient was diagnosed with triple-negative breast cancer, also if the patient has multiple primary breast cancer, synchronous or metachronous, and also particular histology like lobular breast cancer with personal or family history of diffuse gastric cancer. In addition, occasionally we'll see male breast cancer, and definitely, male breast cancer patient needs to be tested. In addition, certain ancestry families like Ashkenazi Jewish ancestry. In addition, you may see patients who have family histories, but maybe not at a younger age. Actually, they may still be eligible by the NCCN guideline. So per NCCN guideline, if you have at least one close blood relatives with any breast cancer at age 50 or below, or male breast cancer, ovarian cancer, pancreatic cancer, or prostate cancer with certain metastatic or high or very high risk groups, they would be eligible. And actually, I would pay attention to that close blood relatives. Actually, this is up to the third, not just the first degree, but second and third degree. So if you add them up, you could find the patient actually eligible. Her mom or father's immediate family may not have these cancers, but their secondary or third degree relatives might. And also, if they have at least 3 total diagnosis of breast cancer in patient and or their close blood relatives, and there's no age limits in this category. And also at least 2 close blood relatives with either breast or prostate cancer of any grade. So I mean, there's a lot of criteria to remember, so I usually just print this out and look, because they are updated also regularly, so I make sure that we get updated information.
Great. And I think there's 2 caveats that aren't really clearly delineated. The first is because it's on a different part of the NCCN guidelines. What if the patient had tumor profiling and has a pathogenic variant?
Mm-hmm.
How is that handled? And do you have a normal reflex pathway to germline testing? Do you always recommend germline testing? How would you handle that?
Yeah, so especially our patient with metastatic breast cancer, we routinely test. So for example, Foundation 1 or other multi-gene gene sequencing studies. And you may see the patient have potential, like a BRCA mutation, and the patient has not been germline tested with. So for example, the specific germline genetic testing, I would always refer these patients to germline genetic testing, because the somatic gene panels may not have, I mean, the gene panels that we're ordering may not really tested their germline, whether this is somatic or germline. In addition, just the way of these assays could miss some of the kind of large gene rearrangement or deletions, truncations. So I would always refer to germline.
So there should be a reflex pathway unless you're using a testing company that does a paired tumor normal. And if you're using tissue, that means you still are going to have to send in a blood tube, because they don't do the germline off of your tissue sample. Yes.
On the question of who to test, based on some studies that demonstrated that the NCCN guideline category using the criteria, ability to detect positive pathogenic mutations versus universal testing, so showing no difference. I'm curious.
So the question has to do with, for the audience, virtual audience, the question about NCCN guidelines and who to test and versus universal testing. So hang tight. I have it in one slide. We actually covered that. So yes, great question. All right. Right there. There you go. There is the question, or answer to your question. So this was a really nice presentation at ESMO this year by Dr. Robson, and basically he highlighted, and they've published now, that differential. So if you strictly use NCCN criteria, depending on the age, if you're over 50 or over 60, and as you can see, there's a high predictive value by following the NCCN guidelines based on age. And I think the key take home for this slide and this message to me was that at minimum, you should be using NCCN guidelines. Now, based on certain factors that influence behavior, germline testing is very inexpensive now. On average, even if a patient paid out of pocket, there are multiple labs where it's $249. So when you compare it to all the other things that we do, this is a one-time test. That's a really very cost-effective, high return on investment test. So when you think about it, universal versus looking at the predictive value of NCCN guidelines plus age, what's the right answer? I have, the first test I ever sent in was 1997, so I'm a universal tester. I believe, in democratizing testing. However, that's a lot of lift for a clinic, for a care team. So I think that over the next 5 years, we will definitely convert towards that. But I think at minimum, using this as a guide, I think is really helpful, and definitely kind of gives us that framework we need. The other thing that I will tell you, it's a caveat, we use the cutoffs of 50. I have never had a problem using pre or postmenopausal. So if you have a 52-year-old premen, that is still within that sort of, I consider them in the under 50 category, because really our cutoff should be that menopausal status. Any of the panel, how do you feel about kind of universal versus just guideline-based, and where do you think that's going?
Yeah, for me in my clinic, we are using mostly NCCN guidelines, but I do favor testing all our breast cancer patients. However, in reality, I still get rejections from insurance when I do that, when I couldn't justify with the NCCN guideline.
Right. And anyone else? I know from a breast imaging standpoint, there's a lot more imaging patients being identified and even tested through imaging centers. How do you feel about that?
Yeah, so as physicians, I feel there is one aspect of being medically trained, accepting, the new following the guidelines, researching, and then there's a whole new concept, and which is dealing with insurances, dealing with the real world, dealing with practicality. I founded and I operate a breast center, and I took this leap of faith because I was tired for working for companies and insurances. But what I realized in my endeavor was that yes, you could be a really good physician, but you really need to figure out how to deal with the getting the best care for your patients. So as we were discussing, coding it right, understanding, and I would encourage each one of you to spend some time. I know we have crazy busy schedules and patients and nonstop and stuff in personal life, but spend your time understanding what will benefit you in terms, or will benefit your patient in terms of coding it correctly. And insurances change, just like these insurances change their CPT codes and reimbursements and the ICD codes and the requirements all the time. We were talking about abbreviated MRIs, which are only 10 minutes instead of a standard breast MRI, which is 45 minutes. Insurances would not cover for that. So institutions have come up with really good self-pay prices like $4.99, 10 minutes $4.99. You have family history, you fit that bill, please go ahead and get it done. It could save, and it could find something much easier. So yes, we all have to deal with it, but it's as important as knowing and practicing medicine.
And there was a question from the website about universal testing, both germline and somatic, is kind of becoming the new vital sign. And I think that's interesting because it is information that, as I show you the next slide, it impacts the patient sitting in front of you today. And as Dr. Ma highlighted, the changing guideline of now any age triple negative. That means your triple negative from 5 years ago wasn't tested if she was, let's say, 62 at the time. So there's a need then to go back, and that going back is a totally new burden on your patients who are walking in the door. And then, Christina, from your vantage point in radiation oncology, obviously we're talking about breast, but really you're seeing patients from across the disciplines. How do you handle any type of somatic germline testing in your world, and how does it impact your world?
Well, I think I agree with the comment made about, starting with NCCN guidelines as a minimum. I mean, in our institution, we're fortunate enough to have 2 genetic counselors who are kind of part of our day-to-day, because I think another thing that comes up in clinical practice is, who takes ownership of this result, and then walking the patient through, subsequent changes in their surveillance. And sometimes, patients can be discussed in a multidisciplinary setting, but then when I'm seeing a patient back to talk about, standard adjuvant radiation, and they haven't, heard about their new BRCA1 mutation, that changes their surgical planning, it changes their surveillance horizon, and depending on the mutation, that also changes their subsequent risk or radiation sensitivity. So, it's helpful, I think, to have kind of a streamline in your clinic process in terms of, who takes ownership of these results, who then walks the patients through. If you're fortunate enough to have genetic counselors, or even there's services that have virtual genetic counseling to refer the patient to, I think those can be helpful as well. So that's kind of how we try to apply it in our clinic setting.
Great. And I want you guys to focus on the first bullet that says 48%. So let's just round up. 50% of breast cancer patients meet NCCN guidelines. So what is the magnitude of that? So every year I like to update this based on the current ACS facts and figures. So we have 300,000 invasive and another 55,000. So let's just say we have 356,000 patients with breast cancer, either non-invasive or invasive. Because in regards to genetics, you don't differentiate out DCIS. So 50% of those patients meet NCCN criteria. That's a lot of patients. Do you think we are testing at present like 175,000 women with breast cancer a year? Anyone? No, not even close. So this becomes the magnitude or the scale of the problem. If we have 50% of patients that just meet NCCN, not even meeting that universal criteria, and then you have patients who've been missed across the years. And we presented at ASCO this past year some data, actually the year before, virtual year, where in our survivorship clinic, we looked at patients on average 10 years out. We had another 13% of patients positive for a germline, either moderate or high penetrant variant. So I think the important part is that, you know, we can't just think about it from the here and now from the patient at diagnosis. We also have to think about the changing guidelines and how it impacts them. Because managing a survivor when you don't have full sort of risk stratification makes it a little challenging because you don't have that full breadth of knowledge in making those decisions. So any comments from the group on this? Because I think this slide just is meant to, not to scare us about the magnitude, but it's meant to put into perspective the here and now, and then how do we handle sort of the volume from the past and going forward into the future.
I think I would like to concur that, especially in our breast cancer survivors, they, you know, the NCCN guideline being updated periodically, and actually, if you see the patient coming back, I would always make sure that, you know, we looked at their genetic risk. Yeah.
So we've added a box into our EPIC template. Most of our survivorship clinics are APP driven, as that's the model that we have built. But the box says, did the patient have genetic testing? Do they qualify today? And then we get them tested. And all of our breast APPs have actually gone through City of Hope training. So we test in clinic based on the fact that we only have this many genetic counselors in the entire state of Kansas. So we don't have access to two in a center. So I think the important part about this model too is sometimes we can't use the gold standard. We have to flex about what's practical, what's possible, whether that's telegenetics, whether that's training APPs. We use APPs partially because they're also the ones co-managing with their collaborating physicians. So I think that, and no offense to all of us in the room, we have to have our business cap on while we have our clinical cap on. We can also bill for our APPs. In the state of Kansas, as in the state of many of us on this panel, you can't bill for genetic counselors. So these are real life challenges and we have to work around them. So important to think about as you're thinking about your workflow and updating your workflow. Great. So why is testing important? We've really covered, you know, several of these to date, kind of thinking about treatment planning, surgical decisions, and so forth. So I'd like to just start with, you know, kind of going across to think about from a treatment standpoint, anything else you would like to add from the panel in regards to using it for your choices and shared decision making.
I think I talked about earlier, you know, BRCA mutation carriers are potential candidate for, you know, olaparib or talazoparib in the metastatic setting, and also high risk HER2-negative breast cancer. If they carry a germline BRCA mutation, they can be a candidate for adjuvant olaparib. So this has not affected too much on neoadjuvant therapy, but it certainly could also affect your surgical planning and also for radiation planning. I guess, you know, one thing is p53 mutation carriers may have a higher risk for radiation-induced secondary malignancy. So it would be, you know, be great to know before that. And also their family members with testings and their risk assessment.
And having a good pathway for those family members. Yep. Anyone else want to chime in?
I completely agree. I think, you know, in patient counseling, it's important to emphasize, you know, there's the journey we need to go on to beat this current cancer, and then there's your future risk and how we are going to mitigate that. And I think especially when we're thinking about, you know, something that can't be taken back, so something like radiation, you know, even factoring in things, you know, in the patient physician co-decision making model, you know, the age of the patient, their performance status. You know, there's some data that for women over 70, you know, you can have equivalent outcomes in terms of breast conservation with radiation. Arguably, that's mitigated by life expectancy, whereas the conversation is very different in a patient with a germline mutation who's under 50, and we're thinking also about, you know, bringing it back to the clinic and logistics, you know, even things like access to reconstructive options after prophylactic surgery. So I think it does become a dynamic discussion where there's different time points based on patient age and performance status that matter, and then obviously this concept of future risk in patients who are mutation carriers.
Yeah, and I think the surgical piece is really a hard discussion because we have a natural trend for patients to want bilateral mastectomies. We also have, as Christina just alluded to, I can't tell you how many patients I would see after they'd had lumpectomy with radiation, and then I saw them for genetic counseling and testing. And so then you're positive, and now your choices are limited, and especially if they'd had any fat grafting or other things like that too. So I think that these are decisions where if we don't have all that information up front, it really does kind of impact the patient across the board. And I think also the one thing I do worry about, and this has also been shown in the literature, is just the act of having genetic testing. Patients actually perceive that as them being at higher risk. It doesn't matter if we're just doing it as part of our process, our pathway. So it's interesting to make sure that we're putting that into context. I use a lot of standard language. We do this for all patients. You know, you have to normalize it so the patient doesn't overinterpret, well, you're doing this because you think I'm at higher risk. And so those are once again, important things to think about in that shared decision-making conversation. So as we think about our workflows, as we think about kind of paired testing, I think that this is a moving target, and we constantly need to be sort of thinking about how do we take new information, how do we take an improved process, and how do you potentially use things that are already important at your organization or for your clinic. So I always think using accreditation standards or best practice, you know, how do you build that into a quality improvement project that meets your ASCO COPE certification, or maybe you're a Commission on Cancer accredited hospital and your practice is affiliated. Any way you can leverage energy resources around improving that workflow, it is selfishly a really good way to go because it gives you the buy-in, and it's a lot easier than having to socialize sort of every single thing you want to improve. That feels exhausting. Sometimes I feel like we're politicians in our own institutions just trying to get the right thing done. But using and going in tandem of things that are already motivators can be really useful. So as we think about these workflows, you know, and we think about, do you have a genetic counselor? Do you have access to telegenetics? Not doing something is the worst part. You can't not do something. So we have to think about that. So from the vantage point of our panelists, anything when you're thinking about workflow, how do you pivot? How do you sort of make those process improvements?
So I guess as a medical breast oncologist, so when patients come to see me, a lot of times they already seen the surgeon. I think our surgeons in our institutions are very tuned with you know, genetic testing. So a lot of the women already been tested. We also have genetic counselor. But we do make sure that to you know, look at their eligibility for NCCN guidelines, and if the genetic testing was missed, we need to make sure that we would order that. But you know, also we do have genetic counseling service to be able to, you know, support our
So, and that's not uncommon. That if surgery is well integrated, it's often done there, but a double check in medical oncology. I know that when our patients call in for the very first time and talk to navigation, we actually have a little genetic screener right away. And so if a patient pings on one of our red flag criteria, then they're actually already scheduled with the APP that's in tandem to the team they've been assigned to, so that we can start the process of getting them tested. So we don't want to wait till now they're seeing, you know, the medical oncologist, and testing comes back really efficiently, but it's one more barrier. So we want that information to be back by the time they see medical oncology. And anyone else from Priyanka or Christina?
So when I see patients, mostly I'm seeing general population. As a radiologist, we're screening general population as well as high-risk patients. Our first way to assess the risk is also the clinical methods, like we use the model like Tyree-Cuzick model, which gives us the risk assessment if there's more than 20% lifetime risk assessment, or if patient has known genetic mutation. We would definitely encourage the patient to have genetic testing if they haven't had it before. But in terms of imaging, we definitely encourage them to have contrast-enhanced breast MRI, especially in patients who have genetic mutations or who patients with elevated lifetime risk because of family history, personal history, previous biopsy of atypical lesions, or any history of chest radiation before patient is counseled then to undergo contrast-enhanced breast MRI as a screening tool, in addition to tomosynthesis and ultrasound based on their age and density factors.
Great. So these are a list of models. This always overwhelms people because who has time to do another model in clinic? So the IBIS is a great tool. We have multiple, if you want to dive in, it's nice because it is considered the gold standard now. Gale model is no better at predicting risk than if you flip the coin, but it's still used for access to therapy. And then we have several germline partners in particular that have chatbots. We're using both actually chatbots that are out from 2 of the commercially available tests, and we actually use one of the chatbots in our safety net clinics in our community. So we actually start by using a chatbot in the community in multiple languages, which once again addresses some of those barriers to access to care. So there's lots of tools out there. It does take a little bit of onboarding and a little bit of commitment, but the nice part is it already builds you starts building you a tree that we can update. It starts building who qualifies. It screens for NCCN criteria. So it's starting that process, and I think the more we can get comfortable using technology, and especially in a lot of our populations where a telephone or their mobile is a common device that folks have, it is really helpful to be thinking about how we integrate technology into our workflows. Real quick, we have some updated utilization of polygenic risk scores, which is the incorporation of single nucleotide polymorphisms. And the interesting part about this is I do sit on a work group where we're trying to determine ancestry in regards to SNPs. So are there some mutations that have more or less risk? Are there patients who will respond better or worse? And so single nucleotide polymorphisms, I think, is going to help us not only in primary and secondary risk assessment, but will also help us understand in some of the kind of next steps in treatment planning. I think we're still early in how we utilize this information, both in affected and unaffected populations, but I think one of the biggest places I see the opportunity for using this information has to do with self-reported versus genetic race. That is a huge barrier that we have in regards to identifying at-risk populations, biology of our patients, and so forth. So I think we just kind of stay tuned. I don't want to dive too deep because it's a deep dive, but cool stuff on the horizon. All right. So real quick, we're going to just have Priyanka just sort of review some of the guidelines out there. And as you can see, if you were a collaborating physician, you're a women's health practitioner or primary care, what do you use? How do I determine what I use? And frankly, can my medical oncologist just tell me in a to-do list what they want me to do as a primary care physician?
So yes, thank you. So there are definitely several guidelines, and it's based on which team is or which group is recommending it. We definitely like to use the NCCN and ACR guidelines. Society of Breast Imaging also supports that. I definitely, and several other breast radiologists like me, recommend annual screening mammography starting at the age of 40, and I would like to continue in patients older than 75 too, as long as they have good quality of life. If a patient is 76 and she's healthy, fit, and going to live up to 90, we must screen them. I've seen patients who stopped screening at after 75 and developed a mass and invasive cancer somewhere at 78, 80, and that could be prevented. So as long as the patient has a good life expectancy, is at least of 5-10 years, we must continue to screen them. Now, we had a heated discussion amongst breast radiologists at Society of Breast Imaging several times regarding the USPS task force recommendations. And I have a few points to mention. The reason I would not support that is 1 in 6 women who develop breast cancer are actually in their 40s. So we're missing screening and diagnosing them, and that makes a significant difference in mortality. They say 40% of all the life years saved because of screening mammography are actually in the women in their 40s. So that's a significant number. We can't ignore that. Also, USPS task force mentioned that women may get anxious about their results, and this may affect them negatively more than diagnosing breast cancer. I would like to say I'm a woman, and I know a lot of women who multitask and handle not only work, home, kids, partner, husbands, whatever. You bring it, they can handle it. So handling test results, causing anxiety and preventing that, I mean, that sounds, I don't know, 10th century to me. So I disagree with the USPS task force recommendations, and I would like to strongly mention that ACR and NCCN guidelines is what we follow and what I would recommend to follow.
And I think the challenge for that is in your primary care referring physicians, they, especially if they're part of affordable care organizations or part of their best practice, they are scored off of USPTF guidelines. So we have a lot of conflict of how we access care. We know that also any of our state Medicaid programs, USPTF guidelines. So a lot of the ways that our patients access basic screening is out of our control and out of our comfort zone. So this is part of that enriched discussion. And I work a lot with rural primary care physicians and survivorship, and I think the most fascinating part about these providers is they want a to-do list, they want those codes, they want smart phrases so that they can support us in our job, but they want literally a to-do list. They are not insulted by it. They need directive instruction with sort of the modifiers to go with that. So this is a very sort of tangible request in my opinion, and when they're faced with, this is just 4 guidelines, we could add like another 7 to these. Like it's unacceptable. Like I want to get everybody in a room and just have them like have at it and then come up with one set of guidelines, because it's really unacceptable for anyone who's trying to decipher this to know, well, which one do I follow? Is it going to get reimbursed? Because you don't have time to go back. You just need to sort of order that test and go forward. But our collaborators want to know codes and they want to know smart phrases. I give them all smart phrases. So this is a way that we can be a good partner to those that refer to us and collaborate on patient care. I think we kind of talked about that. So in light of time, Priyanka, you kind of covered some of these things. Anything else you want to add?
Yeah, so basically just to summarize this slide, women who, first of all, we should always do risk assessment, as there are several tools we talked about. Any woman who walks in our facility, especially African American women and women of Ashkenazi Jewish descent, because they may develop, they may have higher chances of developing as well as more aggressive. In African American women, the cancers could be much more aggressive than any other races we know so far. So in addition to that, genetic mutations we've already covered and discussed. We also like to personalize the screening tools based on patient's breast density. As we all know, it slightly increases your risk of breast cancer. So if a patient comes in for a routine screening mammogram, average risk, and I don't see anything on the mammogram except dense breast, I do make a recommendation, and I would like some support from the referring clinicians, because a lot of time it's a task about convincing the patient, educating the patient, making them understand what breast density it is. I still remember, it's slightly funny. A patient was told she's dense, and she got very offended because she thought that she is a big patient and that's what she's being told. But all I'm saying is the education part comes from everywhere. The oncologist, the primary care, the gynecologist, family medicine. So breast density is always an issue, and supplementing tomosynthesis, which is a great tool, 3D screening mammogram, and breast ultrasound always helps. You could move
Great.
to next. Yeah.
So I think what we're going to do is we have lots of options with chemo prevention, and so Dr. Ma and I are going to quickly just highlight that this exists. We heard it earlier, and then because I want to get to our case discussion where we'll incorporate some of this in. So, yeah.
Okay, so chemo prevention, essentially not chemotherapy, it's just medication that we use in patients with higher risk for breast cancer to reduce their risk for developing breast cancer. So here are some of the recommendations. We would like to recommend the chemo prevention for patients who have a 5-year risk, at least 1.7%, or short-term risk, twice average population risk, and their life expectancy over 10 years. And typically, we would start this at least 35 years old after they're completing their childbearing, because of these are usually endocrine therapies affecting the ER signaling. And for premenopausal women, we have tamoxifen. And for postmenopausal women, we have several options: tamoxifen, raloxifene, and aromatase inhibitors. I think the choice, which one you would offer, for the postmenopausal women is really a balancing of, their, for example, whether they have an intact uterus, do they have a higher risk for thromboembolic events, and also their bone densities. So that it's a kind of a discussion between shared decision making. And there are challenges. For example, there's low uptake a lot of times due to side effects that patients or their primary care physicians may be perceiving, and also provider education, I think, probably play a role.
And in a general high-risk clinic, it's still less than 10% uptake. So in the best of scenarios or the worst, if you write a grant to the NCI trying to get funding in this arena, they will say, but you have all these approved drugs. Why aren't you using them better? So I think that we do have trials, and we have quite a few trials. We also have a lot of emerging opportunities in natural products, metformin, vaccines in part, but it's still challenging. So I think we'll focus our last bit of discussion on DCIS.
Yeah, so just a little bit on DCIS. There are a lot of patients getting lumpectomy, and these patients would need adjuvant radiation therapy. But then afterwards, would you recommend any hormonal therapy? So tamoxifen or aromatase inhibitors. So these have shown to reduce the risk of recurrence and also new breast cancer. So they kind of serve as a two-purpose. Like if the patient have a contralateral intact breast, then that could help as well. So. In addition, recently there's low-dose tamoxifen with 5 milligrams daily versus placebo for 3 years in patients with high risk of developing breast cancer. But majority of these, the population tested actually had, like 70% of them had DCIS history. So, and this showed that tamoxifen 5 milligrams a day for only 3 years actually decreased the risk of recurrence in 52%, also the risk of developing breast cancer. So in patients who cannot tolerate the regular dose, 20 milligrams a day, this becomes a good welcome option. The side effects, when they looked at it, it was much more easier to tolerate.
And has there been a trial yet that compared 20 milligrams to 5 milligrams?
Yeah, as far as I know, there is not.
Right. And I think that's one of the limitations of this study. It compared it to placebo, but not to a standard dose. And in addition, there are no 5 milligram pills, right? So in the US, you have to break a 10. So yes, we'll come right back to you. We have a couple. Okay. So there is the COMET trial, which is currently going on. Doctor, do you want to just highlight that? Because that's in many of your cities and institutions.
Yeah. So a lot of DCIS actually do not progress to invasive breast cancer, and but how to identify those patients, and also to reduce overtreatment for low-risk breast DCIS patients. So the COMET trial is ongoing. So they're comparing active surveillance versus later, treatment upfront. So the guideline treatment with or without endocrine therapy, and in the surveillance group, they would give with or without hormonal therapy, but not to go through surgery first.
That's correct.
Yeah.
So this is yet to come, and as you can imagine, that's a hard shared decision making to get your patient just to do active surveillance. But there's some that are interested in that as well. So I always find this interesting. We always talk about DCIS as the good kind of breast cancer, and it is and it isn't, right? So this requires in clinic, I think in particular, often a longer discussion than being able to really give patients a pathway-directed recommendation, because there are choices, and these are a lot of times based on the patient's preference. So it brings in a whole nother level of conversation that makes it not just about the evidence, but also about patients' goals, patients' preferences, and quality of life. Real quick, just to kind of put this into perspective, I think that if we think about this patient who comes into your clinic with a high-grade DCIS, she's perimenopausal, these are some of the questions that we would think about. And as we think through this, just a couple sort of take-homes. I think the first is you need to remember that genetic testing in DCIS is no different than invasive. So that is one solid group of breast cancer, so we don't differentiate that out. Any other comments, because we'll talk real quick also about a tool for radiation oncology, but in your practice, Dr. Ma, how would you sort of have this discussion? What do you focus on with your patient?
Yeah, so in a patient, for example, she had genetic testing and no BRCA1/2 mutation, we say mastectomy is curative, usually in the DCIS situation. But lumpectomy followed by radiation is just as good with excellent control, prevent recurrences. So if the DCIS is ER positive we do recommend adjuvant tamoxifen as well, especially in a young women with contralateral breast still intact.
So if I'm that 48-year-old woman and I come to you and I say, yeah, but I've heard about this low dose tamoxifen, can I take that instead of like this higher dose where patients have symptoms? What would you say to me?
I think I'll go with the standard dose first because we have more data on that. And then if the patient could not tolerate later on, we can discuss low dose tamoxifen.
Good. I think the hard part about breast patients is they are your most informed consumer. So they have read, they know that some of them come in with data and publications, so it makes it a little bit more difficult of a population to handle because you do have to have those more informed discussions. They're a very health literate population. So yes, standard followed by low dose. And then Christina, I want you to briefly talk about how you use information and in what population would you use a risk tool and how do you talk to your patient about radiation oncology?
So I think, in DCAS we're seeing a similar evolution that we've seen in invasive disease where there's this notion of clinically high risk, but could some patients be genetically low risk, to make sure that we're appropriately selecting patients for treatment and not just making this ubiquitous recommendation for lumpectomy followed by whole breast radiation for most women. So what the Prelude DX study or DecisionRT assay does is, genomically provide patients with a risk score. It sequences a number of genes and actually specifically looks at local recurrence and benefit of radiation. So it has been shown to be predictive of benefit for radiation. And when we actually look at populations where they use like the traditional RTOG low risk criteria, they found that patients who were actually ClinPath low risk, up to 50% of them were actually upgraded to be considered high risk based on their DecisionRT assay. And then similarly, when they looked at patients who would have been ClinPath high risk, so similar to our patient, young woman, high-grade DCIS, more than a third of them were actually genomically low risk, suggesting that we may be able to forgo radiation in those patients. This assay has a lot of, there's a registry study, our institution was part of it, and there's a lot more data coming out, not quite in NCCN guidelines. So I think for a young patient like ours with high-risk DCIS, depending on the final pathology in terms of size, margin status, I'll often use this as part of the discussion, but I find this can be very helpful for patients, let's say, who are older, over 65, over 70, who have higher risk features and want to avoid radiation, to sometimes at least give them some prognostic information so they know what their real risk would be and then what would be the absolute benefit of radiation for their unique situation.
Great. So lots of considerations in our patients and a lot having to do with that shared decision making. In light of time, we know we should all be talking about lifestyle recommendations with our patients, very standard, don't reinvent the wheel. AICR has fabulous tools. And then we'll just save this as a nugget for next time. Multi-cancer detection research is sort of the next horizon, both for how we use it in screening, and then obviously you would think about it as a ctDNA in your affected population. There was a presentation of one of the first tests to market at ESMO. I think it has lots of potential for us, but we also need to figure out how to use it. And if you do this, it's sort of like the old world when patients wanted whole body CTs. You're diving deep. It takes weeks. It takes a lot of tests. It takes a lot of money. How do we put this into perspective? So yet to come. We'll throw that as a nugget for maybe a next meeting, so you'll come and join us and we'll dive deeper into genetics. So I think in summary, I want to thank our panel, which all brought great insight to our discussion. Lots of things to think about as you're seeing high-risk patients, both affected and unaffected. But I think our affected patients, both at treatment planning and into survivorship, have a lot of not only real-time but follow-up that is required. And then thinking about chemo prevention, thinking about how we flex, thinking about how we bring in shared decision-making. There's not one right answer, so it's important to use our partners, use the tools that we have available, and we just want to thank you for your time. So.
Thank you.
So I have a question. Yes. So I was the local PI for the P1 and the P2 trials, and this is many generations ago, but we were very excited that we were going to have a pill to prevent breast cancer. Fast forward to 2023, and less than 5%, I hear numbers like 1 or 2% of eligible patients use tamoxifen. Tamoxifen, I would make the case, is the drug that saved more lives in cancer therapy than any other single pill. It's dirt cheap, and it's not being used. So we have a real problem in this country, and we like to tiptoe around them, but it's a real problem. You know, we spend a lot of time talking about who's high risk. Get an MRI every year, and that's a lot more money than tamoxifen. So what are we going to do about this? Are we going to do a 5 milligram chemoprevention trial? Because I've moved to 5 milligrams based on the data and I can't even convince invasive breast cancer patients to take an anastrozole, because in my new community, Northern California, Northern Nevada, they don't want to take a pill, or they don't want to put anything unnatural in their body. And I'm not overstating this. This is a real issue. So what do we do? What's the way forward?
Well, maybe I can address this to start. So I think provider education is the first thing. When I'm not sure we're doing a good job assessing every woman's risk for breast cancer risk. So I feel like a lot of women are not seeing their primary care doctor until they're having a problem. So we're missing assessing their risk. And then ended up that we see them after they're diagnosed with breast cancer. So, and those are the patients that I see. I think we could do a better job, educating patients and their families, but also, the entire society, having more, awareness of breast cancer prevention. And I think also the perceived side effects from tamoxifen. We say they have, the risk of uterine cancer and also the DVTs. Actually, their risk, although it's elevated, it's low. So I believe in the P1 trial or in the prevention trials with, 5 years of tamoxifen, the risk of developing uterine cancer is in the 4 to 5 out of 1,000 patients. And the same with deep vein thrombosis side effects. So I think we need to educate the society, the patients, the providers, but also need to we need to give it a try first to start.
So I live in a world where I joined a clinic in 1996 that started in 1989. So I'm going to go on record, it's probably one of the oldest prevention, breast prevention clinics. And we've had this, I can't tell you how many thousands of patients that we have seen, it's tens of thousands. But I think the hardest part is there used to be better uptake, especially after P1 came out and so forth. So I think now, a lot of providers don't even talk about it with the patient, or it's part of a checklist and they say, here are your recommendations, but they're not diving deeper into it. So what I envision is, because there's also, once again, so many decision aids. Decision aids are fabulous, but they're so time consuming and nobody's gonna incorporate those in. So I think we need a very easy infographic that you could use in clinic that's like a little, whiteboard kind of thing that you go through with a patient super quick, because the other part is that it's not happening because of the provider education, but it's also not happening because I don't know how many providers I've talked to that just don't really believe in it or think it's not, a useful tool. So how do we give an easy tool, not a decision aid that can be done very quickly, or maybe a one-page decision aid? And that would be great for you guys to share. What would be helpful for you in clinic? And it has to be sort of unbranded, neutral, that has all the basic things on it, and you can customize it. I just think we need a flexible tool, easy for conversation, and has to be less than 3 minutes long.
Thank you. For the interest in time, I'm going to go ahead and transition us into our next panel.
And thank you guys so much.
So thank you all for your questions.